Hello, and welcome to our NCD Academy panel discussion related to COVID-19. As the coronavirus continues to disrupt daily life across the globe, the American College of Cardiology and our partners at the NCD Alliance and World Heart Federation are bringing together experts from across the healthcare sector to discuss the varied impacts the pandemic has had on patients that we care for. Today, we will be discussing how race, ethnicity, and social determinants are influencing outcomes for patients with COVID-19, and many of the similarities shared with non-communicable diseases. My name is Gluckman, and I'm honored to be the moderator for today's discussion. I currently serve as Medical Director at the Center for Cardiovascular Analytics, Research and Data Science at the Providence Heart Institute in Portland, Oregon, and also chair the American College of Cardiology's Solution Set Oversight Committee, a group dedicated to developing clinical policy and tools aimed at closing gaps in care. To get us started, it is my pleasure to introduce our esteemed panelists, Dr. Shrilla Banerjee and Dr. Clyde Yancy. I'd welcome both of you telling us a little bit about yourselves. Please, let's start with Dr. Banerjee.
Thank you very much for the invitation, Dr. Gluckman and the ACC. My name is Shrilla Banerjee. I'm a consultant in interventional cardiology at East Surrey Hospital, which is part of Surrey and Sussex Healthcare Trust. We are based near London's Gatwick Airport, and we span the counties of Surrey and Sussex. I'm the lead for education and co-chair of the British Cardiovascular Intervention Society focus group looking at women in interventional cardiology and why only 4.8% of British interventional cardiology are women. I'm also involved in research from previous times in appropriateness and ethnic differences in invasive management of coronary disease.
Thank you so much for being here and making time for today. And Dr. Yancy?
Hello, this is Clyde Yancy, and I'm delighted to be a part of this NCD webinar. Delighted to work with you again, Ty. We've known each other for years, and delighted to work with Dr. Banerjee. I serve as Professor of Medicine and Chief of Cardiology at Northwestern University Feinberg School of Medicine. Concurrently, I serve as Vice Dean of Diversity and Inclusion here at Northwestern. Within the American College of Cardiology, I'm one of the co-chairs of the Diversity and Inclusion Task Force. And over my 30 years in cardiovascular medicine, I've held a number of positions within the ACC, including being chair of the Guideline Writing Committee for Heart Failure and serving as a lead author for a number of other guidelines and performance measure statements. It's been my passion over the last 25 years of my career to really understand how special populations experience cardiovascular disease and attain better cardiovascular health. So, Ty, remarkably, COVID-19 has really crystallized so many of the areas that I've held an interest in for a very long time, and I'm delighted to have this conversation with you and Dr. Banerjee.
Thanks so much, and thanks for being here. I also just want to thank you both for taking time out of your busy schedules to participate. So, in teeing up much of the discussion today, I thought we might spend a few moments talking about the state of the state. And this is probably well known to the audience, but in the United States, the US Centers for Disease Control recently updated its data on age-adjusted COVID-19 hospitalization rates based on race and ethnicity. Non-Hispanic American Indian or Alaska Natives had a hospitalization rate about 5.5 times greater than non-Hispanic white individuals. And likewise, both non-Hispanic Black and Hispanic or Latina individuals had hospitalization rates about 4 to 4.5 times greater than their non-Hispanic white counterparts. And similar findings have been identified outside the United States. While approximately 14% of people in the United Kingdom are from Black, Asian, and minority ethnic or BAME backgrounds, recent reports have noted a disproportionately higher likelihood of COVID-19 related ICU admission among these individuals. So Dr. Banerjee, Dr. Yancy, do these differences ring true in your respective communities? And what are the other COVID-19 outcomes you've observed with regard to these disparities? Let's start with Dr. Banerjee, if you could share a few thoughts.
Thank you, Dr. Gluckman. Yes, we are seeing a huge and definite disparity in infection rates and mortality from COVID-19 in our Black, Asian and minority ethnic group. When you look at the reports recently published by Public Health England, it conducted a review to understand the impact of COVID-19 on our BAME communities and found that the BAME group are at significantly higher risk of developing initially and dying from COVID-19 infection. When you look at all-cause mortality rates, expected all-cause mortality rates in Black males at the current time, this is 4 times what should be expected at this time. In Asian males, it's 3 times what should be expected, and in white males, it's 1.7 times. So there's a significant disparity in death rates. And when you break down the mortality within the BAME subgroups, the Black males and Bangladeshi males have a 50% increased mortality compared to white males. And again, when you mentioned ITU rates, as you said, whilst the BAME population makes up 14% of the UK population, they make up 34% of the COVID-19 intensive care unit population.
Wow, truly striking. And I know we've seen this ubiquitously across the United States, but Dr. Yancy, you're in Chicago, and Chicago has been, to a large degree, the epicenter of highlighting many of these disparities. Could you share a few thoughts about what's going on in your local background in terms of the Chicago environment right now?
No, Tom, I'm happy to do that. We began paying close attention to this in early March as the data were first being formulated, paying attention initially to the Johns Hopkins website that was beginning to show inclinations that in areas where there were significant outbreaks, it appeared as if populations were being selectively affected. We looked at what was going on in Chicago, and we found something that was absolutely stunning. We found that 50% of the COVID-19 infections were happening in self-described Blacks, and 70% of the deaths were happening in self-described Blacks. But here is the eureka moment that grabbed my attention, and I've been following this ever since. Those 70% deaths that were self-described as Black, almost in entirety, they emanated from just 5 neighborhoods in Chicago, all clustered on Chicago's South Side, an area that historically has been marginalized, underserved, and under-resourced. And so it very quickly went from race alone to being place. What is it about living in those environments that appears to put people at risk? And that launched an incredible dialogue, lots of thoughts, and lots of observations that I'm sure we'll get into as time goes on. I have been following closely the American Public Media Research Lab's website. This is a website that is updated every 4 to 6 days, and it obtains epidemiological data from over 40 of the 50 states and has reasonably accurate attribution of race and ethnicity in at least 90% of the deaths. And it continually demonstrates that there is about a 3 to 4-fold increase in the risk of death for Blacks who contract COVID-19 compared to everyone else. For Latino, Latinx, it's a 2-fold increase, the reference group as whites. To really put this in striking detail, as we stand now, 1 out of every 1,850 Blacks in the United States has died due to COVID-19. If the death rates were the same across this country, at least 14,000 more Black Americans would be alive today. That is a devastating toll, Ty, a devastating toll, and it really merits this kind of conversation.
Thank you for putting that perspective. It is striking to say the least, and I know we're going to unpack a lot of this, and 1 hour will not do this justice today, but let's hopefully talk through some of these issues, because it's not just about race, it's not just about ethnicity. As you said, it may just be the zip code that you happen to live in and all of the associated issues related to that. Before doing that, though, I wanted to sort of touch on a few issues. For years in the cardiovascular community and broadly beyond that, we've been talking about other disparities that exist. And so while much of the discussion has been accelerated as of late, appropriately so because of COVID-19, this issue has plagued non-communicable diseases for decades. It's been true for our most common conditions: obesity, hypertension, diabetes, asthma, COPD, and that's just to name a few of these. Accordingly, are we really dealing with the same basic disparity contributors for COVID-19 as we've seen with non-communicable diseases, or do you think that there's something different? Let me have you, Dr. Yancy, weigh in on that initially.
Yeah, Ty, you really bring up an excellent point, because we have to wrestle with how many of these disparities that we've described over the years, and I've been a part of that narrative, are really related to the social determinants of health and peculiarities about the built environment versus how many are related to some semblance of a difference in biology attributable to African ancestry. You know that I've been very vocal about describing the nuances in heart failure as a function of race. Nuances that we think in part are attributable to either the percent African ancestry versus the percent European ancestry, with some exquisite sensitivity to nitric oxide. That's a tangential discussion, but it's an example of one dimension where African ancestry is important. The same thing for hematologic disorders, thinking about sickle cell anemia, the same thing for certain renal disorders, thinking about APOL1. There are some finite examples where African ancestry, separated from race, has importance in the presence of health and the presence of cardiovascular disease. But in general, what we deal with, for the most part, are the circumstances, the life and living experiences. Some would define it as the lived experience. So whether it's the diet, whether it's the stress, whether it's the neighborhood, but there's one additional variable in the United States populations that we can't overlook, and that's the way in which we as physicians make decisions, the way in which healthcare systems provide care. We understand that bias in today's world, subconscious bias, does participate. It's the only way you can reconcile why more Blacks go on dialysis rather than getting kidney transplant. It's the only way you can reconcile why more Blacks suffer lower limb amputation than having lower leg revascularization procedures. It's the only way you can reconcile why more Blacks receive warfarin sodium for anticoagulation than the direct oral anticoagulants, even when insurance resources are available to allow for the more convenient, more effective therapies to be given. And so it's basically a triocatai. There is a limited amount of important information attributable to African ancestry. There's a big part of this that is the lived experience, the social determinants of health, SES status, neighborhood, cluster density, etc. And there's another part of this that is bias, but the aggregate is what brings about these significant differences, but it's important to nuance this according to the disease process we're considering.
And I'm really glad you brought up the issue of bias. I know subconscious or implicit bias is something that we're going to want to talk about, because I think a challenge for everyone listening, myself included, is how do we begin to overcome this? This is not going to be something that is going to be solved overnight or even a matter of weeks or months, but we need to address this head on. And I hope over the next little bit, we'll be able to talk through some steps that universities, training programs, hospitals, clinics can begin to incorporate to be able to address this. Dr. Banerjee, in the UK, similar issues with regard to chronic diseases, non-communicable diseases, much like Dr. Yancy, are we seeing much of the same underpinnings of that being true for COVID-19 as they are for non-communicable diseases?
Yes, I think what COVID-19 has done for the world is it's uncovered or unmasked the baseline world discrimination, in a way, in that societal discrimination, in that certain populations are more prone to conditions, and those populations are more prone to poor economic status, poor educational status, overcrowding and housing problems, and community issues as well. So I think it's a very similar population when you look at the non-communicable diseases and COVID-19 in terms of those with high propensity to develop these conditions. I think Dr. Yancy's points about the Black populations in America and the other additional pressures that have been cultural and perhaps healthcare generated as well, in terms of the healthcare provision or the lack of it, is very, very interesting. And it's actually very striking and actually upsetting to hear that there's such a disparity in the provision of healthcare just on race as well. It's something that I'm not so aware of in the UK, but perhaps we haven't looked at it in as much depth.
I think your comments are spot on. And we know that race and ethnicity, two of the focus points for today's discussion, don't do this justice. And many of us begin to talk, or traditionally have talked, about social determinants. And this gets into many issues: income and social status, education and literacy. What was your childhood experience like? What does your physical environment look like what kind of access do you have to health services? How well do you practice healthy behaviors? So that I think that there are many who will be listening today who will ask the question, what you're asking all of us to tackle is humongous. It's a momentous redesign of how we deliver care overall. Are there any of these from your perspective, and I'll start with you, Dr. Banerjee, where you feel like clinicians can make a bigger inroad overall? And I know we're going to get into the issue in a moment about how to address implicit bias, but what are those things that clinicians can do? And maybe it's just having a conversation. I will say for the last 4.5 months, I've realized how little I frankly know about this topic. And I by no means claim to be an expert, but I thought I had insight into disparities in care. And it has made me realize how little I know. Maybe it's just the acknowledgement of that and recognizing that there's an issue that is the beginning of coming up with a more cohesive solution. So I'd welcome your thoughts.
Yes, absolutely. I mean, I completely agree. I think if you look at most socially marginalized populations, they will suffer disproportionately during this pandemic. And it's clear that COVID-19, whilst it's not created these health inequalities, it's made them very obvious now. And when you look at the economic factors in particular, we know that the BAME groups tend to have poor socioeconomic circumstances. An economic disadvantage leads to poorer healthcare outcomes and increased prevalence of smoking, obesity, diabetes, hypertension, and all the other non-communicable diseases that are in the NCD Academy. But there's a number of issues. I mean, if you look back, it goes back to the beginning of that person's life in terms of birth weight, childhood experiences, childhood health and environments, and reduced access to healthcare, as you mentioned. And then obviously in the early years, it's reduced income potential and less healthy behaviours that are developed in adulthood. So there's a number of different issues here that have been highlighted by the COVID pandemic and that we do need to address. And I think if we start with healthcare workers, then obviously we can then lobby our politicians and our policymakers to address these issues, because if we don't change this infrastructure, this is going to happen again in the next pandemic and the next big infection that affects the world. And it will be the same groups of disadvantaged people that will suffer again.
I think great points. So I know both of you have brought up the issues, but one of the few silver linings, and there are not a lot, but there are some from the pandemic, has been even greater attention brought to healthcare inequity. And you both have described this well. And additionally, perhaps what is required to help address the disparities that do exist. As you mentioned, Dr. Banerjee, some of these solutions require legislative action or implementation of formal new policies. Other require or necessitate coordination between community organizations, health systems, and healthcare providers. However, for others, I think clinicians and members of the care team are well poised to lead. And Dr. Yancy, I'd like to turn to you because I think a lot of this becomes important in discussing education. And you brought up the issue of bias, and we talk about explicit, which we have hopefully never tolerated, but implicit bias is something that has been below the radar more than it should, and it requires, in my opinion, education, ongoing education. So how do we begin this? How often should it be repeated? What are the next best steps, not just in your university that you work at, but in local communities to educate clinicians about addressing the bias that exists?
So Dr. Gluckman, let's go back to the question you posed just a few minutes ago, because I think it's important to articulate that answer. You said, what can the clinician who's listening to this think about, cogitate, even contemplate doing to address this issue? Because when you really look at the mass of this problem, the social determinants of health, the built environment, the issues of bias that we're about to discuss, it is overwhelming, and it doesn't seem like any one intervention will make a difference. But here is the one thing that every physician can do, including me. I put this in writing recently in an editorial, but this is the time for deep listening. Those of us who make decisions, if you will give me the license to say those of us that have power, should recognize this moment in our history. And this is a moment where those that can control the way that resources are distributed, control the way that the decisions are made, really have a moral responsibility to stop, sit, and practice deep listening. Allow an audience that's never been allowed before to understand what part of this equation hasn't worked for certain groups of people. So I don't want to leave that action item unaddressed, because that is something that everyone can do today. Take the opportunity to sit and listen. Now, we've made a transition and we're talking about bias. There is an author that is highly regarded in the United States, Malcolm Gladstone, and he's written a book entitled Blink. Blink is a phenomenal book because it asserts that all of us have this hyper-fast subconscious neural network that allows us to make immediate decisions based on parent tapes, childhood experiences, our own lived experiences, that allows us to very quickly discriminate comfort and fear. It basically facilitates stereotyping, which is a kind of thought economy. I'm setting this up because we have to authenticate, why do we function with a bias? Not every bias is bad. The bias allows us sometimes to protect ourselves, to anticipate crisis, to anticipate fear. But when the bias is informed by negative perceptions of others, when the bias is informed by adverse experiences you may have had with somebody else that you then extrapolate to others in the same group, that bias becomes functional. And even though you're not introducing a cognitive lever, you are behaving according to that subconscious bias. So that becomes yet another part of this equation. And one of the most important measures that we can take to really unravel bias is to first assess it and then see, as we do in cardiology all the time. Dr. Gluckman, you're one of the leaders in quality improvement. The Hawthorne effect. When we see our decision making, we typically change our behavior. When we see that we're not referring the same number of women for PCI, we change our behavior. When we discover that we want referring the same number of Black women for ICDs despite an indication, we changed our behavior. And so what I'm telling you is that here is the root explanation for why bias even exists. And then fast forward to how it functions in our decision making in medicine and in healthcare. Give you a contemporary example. What happens if you're in an ICU setting? Your beds are limited because you have COVID-19 patients. In the ED, you've got 4 patients that are desperately ill. You've got 2 beds that are available. One of the patients that's ill is an obese, older Black woman that's having respiratory distress. And 2 of the others, 3 of the others are younger, white, middle-aged individuals. Who gets that ICU bed? That becomes a very, very challenging moment for all of us. And how do you provide care for the person that doesn't get that ICU bed? What I'm concerned about is that I've shared with you the statistics that we know. What about the statistics we don't know? The episodes of inaction that are not counted. So that's another issue. I know this is a little bit of an extended response, but I think that bias is another one of those words that's become genericized. And we say it and we allow ourselves to park decisions in that bucket, but we need to bring the bucket out, deconstruct it, and understand what it is and how it continues to influence healthcare.
And Dr. Yancy, you brought up the concept of the Hawthorne effect, which we've all lived through and benefit from in some respects. But you've also underscored the fact that transparency of what we do know, and this doesn't excuse the fact that we need to do further investigation of what we don't know. But we were all discussing before we got on today the fact that we may not even analyze data in the United States or United Kingdom by race, by ethnicity, and share that data widely. So, Dr. Banerjee, I may turn to you and say, what data do you have access? Where are the gaps in being able to even understand the problem? Because as Dr. Yancy very adeptly pointed out, we can only begin to start addressing the problem by actually recognizing that a problem exists.
Well, this is a similar problem to what the problem that we had with research predominantly being focused on male patients. And the way that has been overcome or addressed is that women now have to be mandated to be part of the research population now as appropriate. So we need to mandate comprehensive ethnicity and socioeconomic state data collection as part of our routine health and social care data. It's also, once you have this, we need to make it available to appropriate parties as well, so there can be more responsive and reflective health policy, so that, you know, perhaps if we had the data early in the next pandemic, we may be in a situation to say, right, these are the populations at risk, let's go and interact and intervene so that there is some change made at an early stage of the process. So I do think there's we have to mandate this now in the world. As I may be, correct me if I'm wrong, please, but from what I've seen, the initial data that came from the COVID studies was predominantly from Italy and China, which are the first major countries affected by the virus. And of course, they don't have the ethnic diversity that we have in the UK and US. So it's only really the data that's coming out from the UK and the US that's actually showing the ethnic disparities, because we're the only countries that are looking into this. But obviously, we still need to roll it out further and actually have it much more readily collected and readily available for range of policy.
Yeah, Dr. Yancy, any additional thoughts related to this as well?
No, I think that as we go through this experience, again, thinking about China and thinking about Europe, quite frankly, we were shell-shocked, because as we saw this disease progressing, we really went into this thinking that it was a suite of cardiovascular circumstances that put people at risk for the disease: hypertension, coronary disease, advanced age, chronic lung disease, later obesity. And so it was really an abrupt moment when we had to start reconciling that race and ethnicity play into this equation. Getting back to your question, though, I agree with Dr. Banerjee. There was no reason to articulate anything about race or ethnicity in China or in Italy. But understand that not everyone collects data the same way. Is it an assessment that a clerk makes when a patient walks in the room? Is it a determination someone makes by looking at a surname? Or does a person step up and say, I self-identify as Black? This makes the data so difficult to aggregate and study, because almost by definition, it's heterogeneous, and for some people it's off-putting. So I think there are complexities there.
Great. So let me pivot as a clinician to Dr. Banerjee. How do we begin to have this conversation with our patients? You know, disparities in care may result from distrust of the healthcare system, language barriers, and we work in health systems where translators may be available, but how do we begin to broach the conversation with our patients? And for those that have had disparities, what do we do to regain the trust of those patients? What have you seen work in your community? I know this is early into a long journey, and let me be clear, people have spent decades of their careers dedicated to this topic. So I don't want to in any way imply that this is new as a result of the pandemic, but in a new world where we can begin to make significant inroads, how do we start having these conversations with our patients?
I think it's important to engage communities, and interpreters are great in the healthcare setting, but obviously there's a lot of change that needs to be imposed or performed in the community, at the community level. So I think we need to work with, if you look at the Black and Asian minority ethnic groups, it's faith and community-based interactions that are going to be the most helpful, I think, because those are the trusted areas. So one of the things is to work with the religious leaders to try and form a solution which is provided by the community, with obviously with healthcare workers working together with the community to make an informed policy and actually educate people. So if we can educate the community, and it comes from side-by-side education as opposed to top-down education, it can be seen as something that's for the benefit of everybody rather than a privileged group of healthcare providers telling people what to do. I think we have to work with people, and faith groups are an easy way of bringing people together who are already together to actually work together to try and change some of the issues. So I think that's one of the real areas we need to work on. So I think community is definitely the way forward. We need to work through that potential option to optimize the policy.
So I have to jump in here because this really is an issue that's close to my heart, to be perfectly frank. One of the things that we can do differently is to go to the communities. I think one of the most incredible studies I've seen was executed by a former close friend of mine, former only because he's deceased, that's Ron Victor. And it was the barbershop study that was developed and executed in the Los Angeles area. By going to the community and by recruiting trusted voices, the barbers, the ability to treat hypertension effectively was dramatically improved. I mean, these refractory hypertensives all of a sudden had blood pressures of 119/70. And everyone who was treating them downtown, Ty, hadn't been able to break through. But by going to the community and recruiting that trusted voice, as Dr. Banerjee says, it could be someone in the faith community, but it could be someone that inherently holds the trust equation. I think these are the kinds of things we have to do if we really intend to make a difference here. Here in Chicago, we've got a strong partnership with a faith-based community on the South Side. And we are actively engaged in healthy messaging, in screening, in education, and making clear that the faith-based entity is leading the process, and we're simply providing the infrastructure. But the forward-facing image the community sees is a pastor and all of the congregants, and we are giving them the information. I think these are the strategies that we necessarily have to embrace, because we have to remember there are decades of mistrust that are operational here. There is no one benevolent act that's going to overcome that. And so we have to make a full pivot. I like the word that you've used several times, Ty. We have to make a full pivot and completely reinvent the way care is configured. Not coming to downtown Chicago, not going to downtown Portland, not going to downtown London, but going to the communities where people live.
Well, I love where you've gone with this, because traditionally in healthcare, we've delivered a one-size-fits-all, and it has exaggerated the disparities that exist for all the reasons you both have shared in this regard. You get to a point where you're talking about actually re-engineering who delivers healthcare. And Dr. Banerjee, I'd welcome your thoughts about this, but in the States, we talk about this in a very traditional format. And Dr. Yancy outlined one of a select number of examples of where we've attempted to break the mold here. But do we need to be investing in community health workers, in other types of non-traditional care providers that really not only build the trust, but are really the people that are able to deliver boots on the ground, more effective care to address not only disparities related to COVID-19, but our most common non-communicable diseases? How do we address ravages of obesity, diabetes, high blood pressure, high cholesterol, etc.? I would welcome your thoughts about whether you've seen these same innovations in the UK and what's been most successful in that regard.
Yes, thank you. We do have some small scale projects on a local level. So if we look at where I work, there are local pockets of deprivation in the Asian population here. And just from my own experience, I found that patients have been much more accepting of me coming in and telling them, giving them advice and advising about different lifestyle measures and healthy eating, healthy living, less salt, in the less fat in the food, and all these sort of suggestions, and especially because I can speak the language. So language is a barrier, community and faith are barriers, but if you can overcome some of those and actually find a common thread between yourself and the patients, then I think that's definitely the way forward. I think you're absolutely right. I think we do need to think of a national level community-based healthcare provision, just information provision really, so that we actually are, I think healthcare is all, and a lot of the decisions made in ethnic minority groups about healthcare of patients in hospital, so if a doctor comes along and says this is the way to do things and this is the correct decision, and they may have been subject to bias themselves, then the population are so respectful of the healthcare professions that they'll never challenge it or question it. And I think that respect is sometimes not always very favourable, because it means that no one questions the adverse outcomes in certain subgroups. So that again puts the ethnic minority subgroups at more risk. So I think we need to make sure that we educate, but at a level where it goes all the way through communities. I think faith is usually a great bringer together of people, but it can also be a great divider of people. But if we can use that, the faith communities, the community centres in different areas where there's higher populations of certain ethnic groups, I think we should definitely try and educate, but also educate at the school level as well, because then it means that the education will continue all the way through the person's life. And so then when they're making their lifestyle decisions, they make informed decisions as well.
Dr. Banerjee, let me congratulate you for bringing up the issue of language. We know that in this broad space, as we study disparities, that language discordance alone is associated with about a 15 to 20% worse outcome on all non-communicable diseases, renal diseases, cardiovascular diseases, lung diseases, especially so when we're dealing with children. And so we have to realize that competence, or cultural competence, involves language consonants as well, so that we can communicate effectively. I think that's incredibly important. And Dr. Gluckman, in the very beginning, you brought up yet another very important point. The greatest disparity is not seen in Blacks. The greatest disparity is seen in Native Americans. It is absolutely astonishing what that population has experienced. So it's an exaggeration of all the things we're talking about, not only SES, not only faith, not only culture, language as well. It is really a striking case study of exactly the things we're talking about.
So a key point that both of you brought up is, and Dr. Banerjee, I think you highlighted this in particular, is that going to the community, interacting with patients might be much better received by someone who is reflective of the population that you're in fact interacting with. And I think the American College of Cardiology, it's more than an initiative. It's how do we ingrain diversity and inclusion? And Dr. Banerjee, you led with the fact that a priority for you were increasing the number of women in cardiovascular medicine. But how do we begin to expand the healthcare workforce? And I'm not just talking about physicians, I'm talking about all clinicians, all members of the care team, in a way that's more reflective of the populations that we serve, because I think we do need to rebuild that trust, and we do need to be able to overcome the challenges in understanding cultural differences, socioeconomic status, and that begins by having people on our team that reflect the patients that we most commonly serve. So, Dr. Banerjee, you've done this in a priority towards women, but across multiple different areas. What learnings have you found? Obviously, there are innumerable challenges, but I'd welcome your thoughts.
I think what we need is, as you touched on, Dr. Gluckman, is that for populations to perhaps lose some of their distrust, is to see people like themselves coming and giving them information, guidance, suggestions of best practice and best lifestyle measures, for instance. But my mantra in interventional cardiology is you can't be what you can't see. So you can't aspire to be an interventional cardiologist if you don't see somebody up there on the podium at the ACC meeting, at the BCS meeting, who looks a little bit like you, or who behaves a little bit like you, who sounds a little bit like you. So actually it's very important that this is something that's an action by all of our healthcare organisations. or physician organisations to change people's visibility, so that we see people and we see that we can aspire to be like that person and aspire to be an interventional cardiologist, a professor of cardiology, all of these things. So, but that starts all the way back to education. So in childhood, we need to increase basic health, access to healthcare, reduce child poverty, and increase education and investment in learning. Then obviously, we need to increase the opportunities and access for children who've suddenly been given the vision to actually aspire to be physicians or healthcare workers, and give them financial support. And then within the work environment, we need to reduce discrimination and bias, so that there's reduced stress of the non-white population, non-male population. And there's increased achievement, so people can actually aspire to and achieve what they are able to achieve without the stress of discrimination and bias there. And we also need to empower our diverse population so that they can actually aspire to be a leader, to be somebody that empowers change and influences communities and disease processes. So that's really what it's such a big problem, but we need to start with visibility, and then we need to also influence our policymakers to actually educate our children and protect our children so that their health and their education continues all the way through their life.
And Dr. Banerjee, you brought up a great point. And Dr. Yancy, I'd welcome your thoughts about this. This isn't just about making sure you can't be what you can't see, which I love that mantra, but it's not just about fellowship. It's not just about residency. It's not just about medical school. This is really about ingraining and bringing awareness to individuals in grade school and middle school to recognize the potential of what they can be and how to bring that at a very early age. I'd welcome your thoughts on that.
So I'm going to give you a little bit of a contrarian viewpoint here. I think that everything Dr. Banerjee said is exactly correct. So fully supportive, and I like the idea of you can't be what you can't see, but sometimes you have to envision what you couldn't envision before. Certainly that's what I had to do considering my life journey. But I think it's a bookend experience. I think, yes, it starts in early years. Yes, it starts with who's welcomed into the community via fellowship. I've started working with fellowship program directors across the country now, having conversations about how do we consider the totality of the candidates and achieve greater diversity in the group that we're trained to become a cardiologist. But Ty, here is the key consideration. We're talking about culture change. Inevitably, culture change always starts at the top, leadership. And that's where there's a vacuum of diversity, including gender, sex diversity. Until we see changes in leadership, all of these issues will receive some attention, but the word is not attention, the word is priority. And until we see a change in the mosaic of those that are leading not just cardiovascular medicine, but medicine in general, we'll continue to wrestle with this. We don't need to go through the numbers, but let me just assure you that if we think about the chiefs of cardiology that are persons of color in this country, you're talking to 30%, 33% of them right now. In the entirety of the United States, 3. If you think about deans of medical schools in this country, you can count them on one hand. So you begin to understand that the power still resides where it always has. And it's leadership and the investment of leadership that has to drive these changes. Not saying that persons that are not people of color can't execute on very important social theories and social models, but there is a challenge there. So agree fully, the pipeline's important. We do a lot of things here in Chicago to build a pipeline, but let's not overlook what's most important here. If it's culture change we're talking about, it has to start with leadership, with a deep and persistent and strong investment. And that's where change needs to really happen.
No, I appreciate that. And your points are not lost on me. They're extraordinarily important. let me go to a different direction, and I'm going to be a little provocative here because this has often been the third rail because for a lot of clinicians is getting involved in advocacy, meeting with their politicians, meeting with their community leaders. And maybe many clinicians have not seen it as their responsibility to play that role, but I would argue now more than ever, we are seeing these disparities in care on the front lines, and we have a role. So, Dr. Banerjee, and I'm much less familiar with how clinicians can get involved in the UK, but how might a clinician who's highly motivated based on everything that's been gleaned from the pandemic and before, to start saying, how do I play a greater role in advocacy in my community? How do I advocate for greater access to public health services in underserved communities? Where can they begin?
Well, sadly, the UK is lagging behind the US on this issue. And I was very impressed when I came to the ACC a few years ago to see that you have advocacy groups who go and meet the leaders and actually rally for different areas and different investment and different projects. We don't have that access to the same degree, although I think Public Health England now with the most recent report have suggested quite significant investment is necessary now for the ethnic minority disparity, and in particular looking at the different levels we mentioned, so the education, the economic input, and the sort of work-based life inputs that we need as well for the future. But I think we haven't got the systems that you have actually for advocacy, and that's a real pity actually, because we do need to move forward on that, because we don't have that direct connection with Capitol Hill, for instance, that you have.
Yeah, and Dr. Yancy, I know you've brought your voice to so many different forums, and we've been the beneficiaries of that. But how might a clinician listening today be able to think about ways that they can begin to engage their community leaders, engage their political leaders, and really make inroads in addressing something that we should all be passionate about?
So, Dr. Gluckman, this is a very important conversation because, like you, I have a number of my peers who are saying, man, this really is in a different lane. This is about public policy. This is about sociology. I'm a physician, I'm a clinician scientist, et cetera. But here are a couple of interrogatories I want you to think about. Walk through a COVID-19 unit. Who are the patients in those beds? Look at the bottom line, the revenue line of any hospital in this country over the last quarter. It's red. Think about salaries and how salaries have been affected, going down. Think about our economy. Think about how many businesses have not just halted services, but have decided to end services. Point is this: we live in a very interconnected society, and we have to understand that when health and healthcare constitutes about 22 to 24% of our gross domestic product, when something happens on this lever and this lever gets ratcheted down, everything gets ratcheted down. Here is a key phrase I want you to remember. What COVID-19 has taught us is that all policy is health policy. Because whether it's education policy, housing policy, transportation policy, anything that doesn't create an environment for opportunity, not gifts, opportunity, is going to ultimately be manifest as something in the health bucket. And we have paid a dear price for the failure to really support all of the resources necessary, particularly in certain communities. So keep that in mind. All policy is health policy. And any of us, particularly in leadership, that have had 20/20 vision of what's happened in the last 4 months, now is the time to speak up and articulate this so we don't experience this yet again.
And Dr. Yancy, just to follow up, I would not consider myself historically a public health clinician, but this is really a public health problem. And so if I'm hearing you correctly, this is about all of us owning a public health crisis that's occurring in the UK, in the United States, and for that matter, worldwide. And so if someone said, listen, you've convinced me, it didn't just require watching this series, but I've learned a tremendous amount, where can they get more involved? What are the things that they can do to make a difference? Even if it's in a world of incrementalism, they can begin that conversation in their own communities.
You know, a lot of small steps causes a march. and a lot of marches cause a movement. So I wouldn't fear being incremental. But recognize what you just said, Dr. Gluckman. One of the most important but least resource aspects of health and healthcare is public health. But in every community, even in most medical staffs, there is someone that's a champion of community engagement, public health, preventive services. Those are the people that need a knock on the door and say, you know what can I do to help you? Are you advocating for something in particular? Is there an initiative we need to do? Do we need to go to hospital administration and talk about standing up a new program? Again, a lot of small programs is how we begin to make change. So I think what we all have to do is not be intimidated by the enormity of the problem. Recognize that it's the small steps that we take at a local level that begin to change health and healthcare.
Great. So lastly, in reflecting on even today's conversation and what the last 4.5 to 5 months have taught me, I've realized, frankly, how little I do know, and this is a learning process for me. Dr. Banerjee, starting with you, I'd welcome perhaps what you believe have been the greatest takeaways that have occurred during the pandemic. But as we've all highlighted today, this is a reflective picture of non-communicable diseases that we've been dealing with for decades. Just your big takeaways from today's discussion.
So my tagline would be, following on from Professor Yancy's point, would be that investment in a nation's health will result in a nation's wealth, really. So the long-standing health inequalities that we know about and that we've known about for many years has been exacerbated and highlighted by the COVID-19 pandemic. And we mustn't lose this opportunity to improve the health of the less privileged populations by investing in education, housing, policy, transport and processes to reduce the levels of non-communicable diseases such as diabetes, chronic lung disease, obesity and cardiovascular diseases. We mustn't forget the significant detrimental effects as well that racism and discrimination have on mental and physical health. Fair enough that COVID-19 doesn't discriminate, but the world still discriminates against populations. And we also know that there's a definite biological effect of this discrimination. The fight-flight over egging perhaps, or the over response causes long-term increased risk of cardiovascular disease and diabetes, and we must definitely address that as well. So there's socioeconomic factors as well we need to look at, but obviously there's societal things we need to look at as well in terms of racism, discrimination and bias as well.
Takeaways. Dr. Yancy, I always relish your last takeaways and thoughts.
Thanks so much, Dr. Gluckman. Let me echo Dr. Banerjee and thank her for her clarity, for her communication, for her conviction about doing the right thing. Let me remind all of us that medicine really is a noble profession. We're driven to this profession because there's some part of our DNA that wants to help. There's some part of our DNA that is attracted by a service mentality. There's some part of our DNA that feels that it is our duty, it is our calling to help our fellow man in need and to bring our knowledge, our resource, our strength, our conviction to make life better for another human being. Let me just say very clearly, COVID-19 has been a generational moment in medicine. This is one of those moments in time where a fundamental change needs to happen. We had that before when we had to make the pivot to electronic health records. We had that before when we had to get away from the completely private practice model to different kinds of care delivery systems. Those are very sterile things. This isn't sterile. This is very real. This is a generational moment in the arc of medicine where now more than ever, we have to understand the social circumstances of our patients. We've studied the biology very carefully and we're adroit at deploying the biology. But now we have to be aware of the sociology and not lose this generational moment. Medicine has been remarkably resilient. We have consistently risen to the occasion and generated better outcomes for more patients by deploying our knowledge, our insight, our discovery. This is a new era of discovery. This is a new era of implementation. This is a new era of service. I really believe in medicine. I believe in all of you that are watching this. We are the noble profession, and I'm confident that we will rise to meet these circumstances, and that as we navigate our way out of this, and we will be better physicians, we will be better healthcare delivery systems, and we will take care of communities that will be healthier. Thanks very much.
Very much. I agree completely that we'll be better off on the back end from this. You know, for me, this has been a really informative conversation, and hopefully for you both as well. I wanted to extend special thanks to both of our panelists as well as the viewers for taking time to join. I hope you will tune in for our next discussion coming soon, where we'll go into much greater detail on how best to manage chronic diseases alongside COVID-19. Thank you again for joining, and please stay safe.
Thanks so much for the participation.
Thank you for the opportunity.